Okay. So thank you very much for your kind introduction. So good afternoon, everyone. So now we still talking about tuberculosis, and I'm gonna talk about the debated topic. So many doctors in the region has not performed the TB preventive therapy. So just try to convince you today whether. So just let's start with this slide that the early or same-day ART reduced the TB approximately 70 to 80%. And when the TPT is added, so the benefit is beyond the TB prevention only. So it can reduce the mortality rate about 40 to 50%. And the protective effect is lasts for more than 5 years. So it's not just reduce the TB cases, but it also can reduce the mortality rate among the PL-HIV. And also, the ART with the TPT can have additionally 30 to 35% reduction in TB in high TB burden setting. So today I will cover so who should get TPT and how about the TPT regimen and also the ART regimen. So why TB prevention matter in people with HIV? As Ajahn Gampon has mentioned that TB remain the leading cause of death, especially among people with HIV. And HIV increased TB risk about 14 to 20 fold, and more than 2-fold higher mortality during TB treatment, and also after TB treatment, for example, post-TB diseases, and also with the TB, with the active TB, the patient is at risk for drug-resistant TB, the post-TB lung diseases, and non-lung diseases, for example, increase the risk of cardiovascular disease, increase the risk of ischemic brain disease, or even for lung cancer. So they are more evident to support that the active TB or TB infection in the past can increase the risk of this comorbidity, and especially with the lung cancer. So the TB can occur in any CD4 cell count, and so prevention can reduce the incidence of TB almost 60 to 90% and reduce mortality rate. So why not? Why not we implement the TPT? And also, the WHO recommend that the TPT should be an essential component of advanced HIV care. If you look at this graph, you can see that so the risk of active TB increased 2 to 5-fold soon after HIV infection. And it's much higher, almost 25-fold if CD4 less than 200. And even the patient received ART, or how to use that? Maybe just, okay. Even the patient, so after receive ART, you can see here, this is the risk of TB, right? And after receive ART, viral load declining, and CD4 increasing. So the risk of active TB still about 4 times greater than the baseline. And risk of active TB remain for above baseline even after CD4 cell count have recovered. This is very important message. And we had the opportunity to look at our cohort from the incident TB after ART in 15 hospitals. so among 9,000 people. And we found that the incident TB was very high during the first 3 months, 6 months, and 1 year. And so it takes time for ART, so maybe after 10 years, so the risk is equally to general population in Thailand. And when we look at the risk factor, you can see here. So the strongest factor was viral load suppression and higher CD4 cell count. If CD4 higher, but if viral load is still undetectable, so the risk of TB still higher than the lower CD4 with viral suppression. So it's very important that if the patient have viral suppression, even they have low CD4 cell count, the risk still lower than the patient who have high CD4 cell count but detectable viral load. So another issue is that if we leave the patient to be active TB, so the clinical diagnosis is also very challenging. So Maria will talk about the HIV TB later after this section. So I just point out that the more advanced HIV is more atypical TB with a smear negative and increase the mortality rate among this population. And also increase the cost of the investigation. We have to use this molecular diagnosis test, including urine lamp for advanced HIV patient. So it's add on the cost. And also, with the HIV patient and with disseminated patient, the sensitivity of the gene expert is lower compared to non-HIV. This induces more challenges in this population. So just start with the case. So I have 28 years old MSM with newly diagnosed with HIV, very low CD4 cell count at 110, and high viral load, and no any symptom of active TB, no known of TB contact, and live in Thailand, which is a high TB burden setting. So just make a vote. So is this patient eligible for TB preventive therapy? Yes, immediately. Yes, but only after ART. No, CD4 cell count is too low. And D, unsure. Please vote. Okay, so thank you very much. So I just like to say that you can say yes immediately, but with ART, okay? I will show you why because of the study support. And also yes, but only after ART. So the key message is that we want to start ART as soon as possible, okay? And then start TPT. So for this patient, TB risk assessment in this patient is very high. He lives in a high TB setting, advanced HIV diseases, and also ARV-naive population. So these are the risks of developing TB. So HIV causes CMI dysfunction, CD4 T cell depletion, impaired macrophage activation, and then it's about 30 to 40% risk of primary TB infection, and about 10% per year thereafter for the reactivation of latent TB. So why CD4 can occur at any CD4 cell count? The very important is the ART and also TPT to block this cascade. And this slide just show the HIV is included in high risk of TB. So this is a recommendation for TPT in people with HIV. First, close contact. For the close contact, you don't need to check whether they have a TB infection or not. In low TB burden country, they recommend only for positive screening tests for TB infection. But for WHO, this is for high TB burden setting. So they recommend all people with HIV should receive, all adult and adolescent HIV should receive TPT regardless of CD4 cell count and regardless of TB infection. So, but the most important, active TB should be excluded before starting TPT. So for this case, no any symptom of TB, right? And then chest was normal, sputum gene spurs was negative, and also we did the urine lamp. So now in Thailand, we integrated urine lipoamidinoamidine, urine lamp, in the advanced HIV disease package. So it's also negative. As you can see here that the expert on molecular tests so reduced mortality by 24% versus smear, and expert ultra increased the sensitivity of the test about 12%, especially among people with HIV and with a very low burden of TB. And urine lamp especially very useful if CD4 less than 200 for inpatient and less than 100 for outpatient. So excluding active TB is the most critical step before starting TPT, as Ajahn Gampon has mentioned. So we have to make sure that the patients are TB infection. It's not in this category, asymptomatic TB or subclinical or even symptomatic TB. This is very important step. So the next question, would you require TST or IGRA before starting TPT in this patient? So yes, always. B, only if available. C, no. D, depend on CD4 cell count. Please vote. Okay. Oh, thank you very much. So the answer is that, so A, B, C they are correct the answer. Yes, if you are in US or in high income country, so it's required. B, only if available, or no as well in this region. So I just would like to say that we should not delay TPT because of the TB infection testing is not available. So the WHO guidelines support universal TPT in people with HIV. So now we are in the step 3, right? Step 1, we identify whether these patients are eligible for TPT. Step 2, the clinical evaluation to rule out active TB. And step 3, testing for TB infection. So now the WHO also endorsed the new skin test. It's called tuberculosis antigen-based skin test. And so the step 4 is a treatment. So this is affordable and simple. So in Thailand, we plan to import the CYTB to replace IGRA because IGRA is quite so expensive. Okay. So on this Friday, Dr. Sivaporn will talk about this test later. This is the guideline for Thailand. We focus on ARV-naive population or people with HIV who receive ART for less than 12 months because they have high risk of active TB, and any patient with re-engaged to care, or any patient with lost to follow-up, okay, and without active TB. So we screen with 4 symptoms, the visual 4 symptoms, and also with urine lamps for very advanced HIV. So you can start with like if CD4 less than 200, whether the patient want OI prophylaxis. So for me, I think PCP prophylaxis is not required if CD4 greater than 100 or 150. Or if the patient don't have any symptom, because once you start integrase inhibitor, so the CD4 cell count increase rapidly, and also the viral load decrease rapidly also within 3 months. And so then start TPT later, because we are afraid of the toxicity, overlapping toxicity with the ART. However, the Dolphin 2 study is just published last year. So they look at whether the TPT can be started at the same time with ART or not. So this is very small patient, just 75 patients to receive ART. So 50 with 3HP and 25 with isoniazid. And the data show that it was safe, well tolerated, and achieve rapid and maintain viral suppression, even though the DTG-C TARP is 72% decreasing, but the viral loss remain undetectable. So next question. So he started with TLD for 1 month. Which TPT regimen would you choose? A, isoniazid, B, 3HP, C, 1HP, and D, not sure. Please vote. So I just want to check whether your country have rifampicin available. Okay, so thank you very much. So majority choose 3HP. So I think you can choose whatever, but we have a clue to think about which regimen should be used. So even 6H, 9H, 3HP, 1HP, I think the efficacy is almost similar. So it's just different in drug-drug interaction and completion rate. So the shorter regimen would be better in terms of completion and programmatic success. So this is the TPT regimen available. So we have, so for HIV, we prefer 9 months isoniazid, but in Africa, they use 6 months. And also 3HP is isoniazid rifampicin weekly for 12 weeks. And 1HP is isoniazid rifampicin daily for 28 days. And also 3HR, isoniazid rifampicin for 3 months. But just remember that for rifampicin, you have to increase DTG for the whole course of this regimen. So it's almost 3 months. Also, rifampicin, we preserve for the patient exposed to the index case with isoniazid monoresistant. And the visual just add the levofloxacin for MDR exposure. So based on the 2 studies from Vietnam and from South Africa, the V-Queen and TB sham, even though it's a reduction, it's almost 50%, but it's not statistically significant, but it's still worth to use it. And the next, the new, so we also waiting for the big study of TPT in MDR patient is called the Phoenix study, comparing between Delamanid versus isoniazid. So the data should be coming out in next year. And so what you want to choose between 3-HP and 1-HP, you can choose any. Okay, but the data from the impact for TB, they found that with the 3-HP, so in ARV-naive population, is some kind of their adherence it was lower compared to 1-HP. This is for the patient who just start ART. So if they are familiar with the ART regimen, it's okay to start with 3-HP. So it depends. And also they consider the 1-HP for adolescents that may have adherence issue. So I just say that just look at the drug-drug interaction, duration, and pill burden, and risk of hepatotoxicity. So 9H have greater hepatotoxicity than 3-HP or 1-HP. And also, the most important, patient preference and feasibility, not just a doctor preference. Even we like 1-HP, if they don't like that, they would not take it, okay? So the polling question 4. So he just started ART, TLD for 1 month, right? And the doctor and the patient choose 1-HP. So what would you do with the patient ART regimen? Just stay with the same dose with the TLD, 1 pill a day, or increase DTG, 1 pill, or switch to TAP FTC DTG, or bictegravir TAP FTC. Or not sure, please vote. Oh, wow. So thank you very much. So the answer, so I think A or B is correct answer. It depends your belief, whether you think that the TLD only is enough. I just give that. I just show that. So both rifampicin and rifampicin can reduce the ART, right? I don't have time. I just go to this slide. You can see that rifampicin reduced the DTG almost 54%, and reduced the bictegravir almost 75%. This is for rifampicin. For rifampicin, it just say decrease, but usually decreased for daily is almost the same as rifampicin, actually. But for weekly, it's about 80% effect. So, and the question, I will show DTG later. The question is whether TAP can be used with rifampicin or rifampicin. What you say, yes or no? TAP. I would say that, so this slide just show that this is TAP, and they look at tenofovir diphosphate, right? This is before starting rifampicin. This tenofovir diphosphate level, so during rifampicin, this is from TAP, and this also TDF alone without rifam. You can, the blood level decreased 50%, and also intercellular level of TAP decreased by 36%. However, it's still 4 times higher than TDF without rifampicin. I just want to confirm that if TDF can be used, why not TAP? So why European guideline and also Thai guideline? This is for TB drug. So Maria might talk about this later. This is for TB drug only. So you can choose between TAF or TDF plus FTC or plus lamivudine plus DTG 50 mg BID. This for TB, right? And how about the latent TB? That one is active TB. The latent TB that we use, like rifapentine. For 3HP, the data from dolphin trial support that no DTG dose requirement with 3HP. How about 1HP? So 1HP, I just want you to look at this. This is, we compare DTG concentration, this before 1 HP. This from we call A5372 study that look at 1 HP with DTG 50 milligram BID in many countries, including Thailand, Africa, and Brazil. And this is the DTG alone before starting 3HP in dolphin trial. This is mainly in Africa. You can see here that the level is higher compared to dolphin trial. And when we look at that, because of, we call the oral clearance is slower in A5372. Because of what? Because of Thai patient in that cohort. I can say that Thai patient or Asian ethnicity might have effect to oral clearance of the drug. And it means that so the drug can be higher in the breast consent in the breast, so it's higher. So Taiwan study also support that when used with 1 HP or 3 HP, the DTG doesn't require the dose increase, and also with the BF tab as well. So you can see the efficacy still remain high. So this brings the WHO to recommend that both 1 HP and 3 HP do not need DTG dose adjustment. It makes us so very simple. So this also our study from 15 sites among Thai people with HIV. So we select the patient with, to enroll into this study. So with the early using with the efavirenz, and then once DTG available, we just go with DTG single pill only. I mean the TLD single pill only without DTG dose increase. We do this before the WHO recommendation because we think that Thai patients usually have high ART concentration. And you can see here that the 1 HP and 3 HP, the efficacy of TB is the same. So we have, during the 3 years, no active TB at all. So TB developed after completing 3 years of the trial. And we have also very few death cases. And you can see very few side effects. Even hypersensitivity reaction is also very low. And discontinuation are also very low. So, so in terms of HIV viral load, even without dose increasing, so the patients still have high viral load suppression. So, so just to confirm that you can use any 1 HP or 3 HP without ART increasing. And also, just I just go with this just briefly. So from our cohort, also another cohort, when we start TPT, you see that we don't have any new TB case after the TB, after TPT at all, compared with isolated or without TPT. You can see here the incidence was very high with no TPT. And just summary that, so I just prefer 3 HP or 1 HP, and for Asian population, just use it based on the body weight, so to reduce the toxicity, okay? And also with DTG no dose adjustment. and also for 1SP as well, just based on the body weight also. And I just go with this. Just my conclusion, take-home message. So we need to complete the loop: case finding, treat TB, and prevent TB. Otherwise, we cannot get rid of, or we cannot end TB. And also, very important that early ART combined with TPT is greatest mortality reduction, especially in advanced HIV. So TPT should be integrated into routine HIV care. Thank you very much for your attention.